Awesome. Thank you for the generous introduction. Can you still see my screen okay? I think I took the sharing back, so hopefully we're still good there. Okay. Fantastic. Well, again, thank you everyone for attending. Hopefully this is somewhat of a hot topic or a frustrating topic, and the goal today is hopefully to kind of reiterate or sort of understand that background of why this is a challenging issue, not just in the pain and spine care, but for society at large, and especially a lot of our primary care providers. So we'll also talk, or the main part of this talk will be to focus on some emerging or relatively newer therapies. I'm guessing probably a lot of you have not heard of them, and talk about the evidence for those, and hopefully fill in some blanks and some potential shortfalls in treating chronic axial low back pain. So kind of like I mentioned to the objectives today is just to go over some background slides, understand how widespread of a problem this really is. Hopefully you'll walk away understanding not only my frustration as a specialist, but the frustration that a lot of physicians and APPs encounter when treating these patients. And then again, we'll focus on a couple, at least 3 or 4 novel different therapies, but also specifically look at the evidence in favor or maybe not in favor of some of these newer and emerging therapies. My disclosures are listed here. I have done and still do some work for Vertos, which is now actually part of Stryker. I continue to do some consulting for Stryker as well as Spinal Simplicity. None of that's relevant to this. None of those therapies that I consult for are actually relevant to this talk at all, though. So just so you know who you're talking to, I think I know a lot of you or most of you, but just for those who don't know me, I am originally from Denver, Colorado. I did pretty much all my training in Colorado, at least initially, my internship at St. Joe's and anesthesiology residency at University of Colorado. Ventured next door to the University of Utah, and that's where I learned a lot of this pain management stuff that I do pretty much exclusively here now. And I've been practicing in Boise ever since 2021. So just so you know who you're chatting with today, that's me. Again, like I talked about in the intro slide, we'll just kind of look at the current state of chronic low back pain. We'll do some definitions of what is chronic low back pain. We'll focus on the current repertoire of what we do currently to treat chronic low back pain. And then, like I said, we'll focus on some of these emerging targets or pathologies, and then focus on the actual therapies designed to treat those emerging pathologies while highlighting some of the evidence along the way for each one of those therapies. So axial low back pain. It's a lot of things, sort of like I alluded. It's obviously a bane of many people's existence, a lot, myself included some days, even though this is what I signed up to do. And it's a general source of frustration, right? Not just for patients. Obviously, they're the most impacted by it. But you can broaden that to the care team in general, right? So it's not just, again, physicians, providers, APPs, but it's also our support staff, right? Like my support staff every day gets, understandable inquiries or frustration from patients, right? They still hurt. Pain puts you in a bad mood. It can make you short-tempered. And so that can take a toll, not just in the actual clinic exam room or the procedure room, but can affect sort of the broader, like I said, the medical staff as well. Obviously, family and caretakers are intimately involved in this process. You can imagine if you're in pain all the time, that affects your mood, your sleep, your disability and function. That puts strain on your relationships with your loved ones, and obviously is a burden, like many other chronic conditions, for our extended families. And of course, if you even take another step back, employers and society at large, right? Low back pain, as we'll see in a couple slides, obviously contributes to a lot of disability, time away from work, time out of the workforce, et cetera. So obviously the societal impacts are not to be ignored either. But for some of us, like myself included, people who do this all day, every day, and spend a lot of time thinking about how to properly diagnose and treat axial low back pain. For some of us, it's job security, right? So kind of a glass half full, glass half empty sort of phenomena here. So stepping into the background a little bit, the overall economic burden of low back pain. Well, it's obviously a public and occupational health problem. It's, like I've said multiple times already, it's a socioeconomic burden, not just for patients, but society at large. So to put some statistics to that, just to sort of frame the conversation a little bit, 84% of the general population will experience low back pain at some point in time in their life. So it's really not a question of if, but it's really more of a question of when, and not just when it will strike you or someone but how severe will it be? And we'll talk about that sort of biopsychosocial interplay a little bit. Acute low back pain, so recent onset back pain, it's actually the second most common reason patients present to the PCP, but to healthcare in general. And even when that acute pain has become more of a chronic long-term issue, chronic low back pain, excuse me, still easily cracks the top 10 reasons why patients continue to come to the hospital for care and the PCP office. It accounts for 30% of extended sick leave. So again, time out of the workforce. It's implicated in at least 1/5 of overall or all work accidents. And not surprisingly, it's the leading cause of exclusion from work for patients under the age of 45. So again, our workforce that's supposed to take care of baby boomers and our older patient population, it's causing those people, family and friends that and work with every day, to be excluded from work. And this is not uniquely an American problem or a US problem. By just quickly looking at this overall burden or incidence of axial low back pain, certainly it tends to affect the industrialized countries a little bit more. I'm not really sure what's going on in the Balkan Peninsula here, but the point of this slide is really just to say, yeah, there's some countries, maybe Asia has less of a problem or less of an issue, but it's not uniquely a domestic issue, right? It affects every patient sort of across the world kind of thing. To that point, it's also a problem that's really not slowing down, right? So this is a projected graph of disability adjusted life years. So to put that simply, and I'm not an epidemiologist by any means, but it's basically a metric we use just to sort of quantify the overall burden of a particular disease. So low back pain in this case, we're roughly somewhere in here in 2020, and it looks like we're kind of at that inflection point. And again, aging population, et cetera, where these numbers are not going to get any better, right? As population grows, so does the burden of axial low back pain. Interestingly, it looks like females have started to surpass our male population, sort of accounting for a larger proportion of disability and back pain. And again, if you take these numbers all the way out to 2050, so just a short 30-ish years away, we're almost talking about 1 billion people that are going to be affected by this issue. So again, probably not news to most of us, but it's always kind of interesting to look at these statistics from time to time. So what are the risk factors for axial low back pain? Well, it's a lot of the common things that we think about with any other sort of chronic comorbidity or condition, right? Smoking, obesity, always a risk factor for pretty much everything. But when it comes to back pain specifically, low physical activity levels, also, again, not super uncommon, but patients who have high physical stress at work, so manual labor type jobs, obviously with advanced age, the longer any of us, the more time on earth our spines have had to take the toll of living life. Not surprising that advanced age plays a role. And then, of course, comorbid psychiatric conditions, so primarily anxiety and depression. This little pictogram off to the right side here, despite these well-known risk factors, it's really hard to predict, even patients with similar trajectories, right? So similar MRIs, similar life stories, similar vocations. It's interesting to me why some patients, they have low back pain, but then it goes away and they move on and they still live a very fulfilled life. But then there's other patients, like I said, with similar sort of trajectories in life where this becomes really defines who they are and limits their function. So again, it's just this complex biopsychosocial interaction. Again, that really is what can not just predict or determine how severe the back pain is, but recovery and response to treatments and things like that. So let's talk about definitions of low back pain, but specifically axial low back pain. So what are we actually talking about? So when I say low back pain for the purpose of this talk, I'm really referring to axial low back pain. What the heck does axial mean? Well, it's pain that's confined to the lower back, meaning it doesn't travel, it doesn't radiate to other areas of the body. What I mean by axial is that it's not radicular pain. So it does not shoot down the leg. It doesn't have like a dermatomal type distribution. It's not like that sciatica sort of pain that patients and do complain about. Keep in mind, you can have axial back pain and radicular pain, but we're talking about the chronic low back pain. We're talking about just that axial in the low back area. Anatomically speaking, that's what's highlighted in red here. So basically below the ribs, but sort of above the gluteal fold, above the lower or upper buttock kind of belt line area. That's what we're talking about from an anatomic standpoint. It's often a mixed pain, right? So sometimes it's your usual pain pathways, nociceptive pathways, but sometimes it's more of a neuropathic type pain, more of a burning type pain. But sometimes it's inflammatory, right? And more often than not, it's a mix of all the above. So not surprisingly, when patients come in and complain of back pain, you'll hear every description under the sun. It's dull and achy, but it can also be sharp and intense, burning. It could be kind of mild and tolerable, but it can be really severe, debilitating all the time. So like I said, the descriptors to me are often less helpful. And again, like I mentioned with that complex biopsychosocial interplay, it's still a bit of a mystery, right? It's a little bit mystified, and hopefully by introducing a couple new concepts here, a couple new sources of axial low back pain from a pathologic standpoint, hopefully we'll start to demystify a little bit of the different complex sort of medical things that go into just diagnosing back pain. What about causation? Well, there's basically two ways to define low back pain. There's specific causes or there's non-specific causes. And this is straight from the World Health Organization. So specific causes of back pain are kind of what it sounds like. It just means, hey, there's something that we can point to that says, okay, because of XYZ process, this is clearly the source of your pain. That could be if we have very obvious moderate to severe spinal stenosis at a single level, patient has claudication symptoms that do affect the lower back. Great, there's a specific cause of back pain. If they have positive facet loading, positive quadrant loading, it just has that arthritic, facet joint kind of pain. Again, we can point to that and say, okay, clearly that's what's driving your back pain. Non-specific is just the opposite. It's saying, we don't know. It's saying, there's a lot of things that can cause back pain. Some things we know, some things we don't know of, but there's not an ultimate source that we can point to. A very staggering statistic, and really sort of the impetus behind this entire discussion today, is that 90% of these cases are actually non-specific. So to me, I wake up every day and I'm thinking, man, like I'm in a specialty where 90% of the time I don't really know what causes this patient's back pain. So again, it's a very interesting statistic, and hopefully by sharing some of these more novel, like I said, novel targets, novel interventions, it'll hopefully start to make a little more sense of, maybe we're finally moving in a better direction treating low back pain. So let's just stop and recap for a second. So I've told you that low back pain, it's a big problem. I've told you it's a global problem. I've told you that it's a problem that's not getting better anytime soon. It's only going to get worse. I've told you we basically have no clue why it happens, or most of the time we don't know really kind of what's causing it. So you're probably maybe feeling a little bit of despair right now. And that's one way to look at it. Right? You could, and I think this prompts the question, right, is how do you approach a patient with low back pain? You could be like this character on the left side of the screen, where you could just be like, oh my God, another back pain patient. I don't know what to do with this person. Send to the pain clinic, whatever, right? Or you could take the approach that I really try to internalize, and you could say, okay, look, yeah, right, there's a lot of headwinds here. There's a lot of unknowns with back pain, but look, we can work through this together. You can form a therapeutic relationship with the patient, and you can take a more glass half full approach and still really have a good impact on that patient's life over the long trajectory. So again, I think, don't let the situation define you. You can define the situation, kind of thing. If you need a little inspiration at this point of the talk, Winston Churchill always has something really smart and savvy to say. He says, difficulties mastered are opportunities won. So again, trying to keep a glass half full perspective here. But if you're not so much a history buff, you can always look to Dave Chappelle for some comic relief and say, modern problems require modern solutions. And again, that's sort of foreshadowing the next part of the conversation here, as far as these hopefully more modern approaches to low back pain. But before we jump into those newer, again, emerging targets or therapies, if you will, to understand where you're going, you have to understand where you've been. I don't know where that quote comes from, but I put it up here. So this is stuff we're all familiar with. Patient comes in with low back pain. Obviously, you're going to reflexively do some physical therapy. Never the wrong idea. You might order some analgesic medications. Just like any other treatment, it's a bell curve, right? There's some patients that do really well with analgesic medications, opiate or non-opiate. And then there's a lot of patients, though, that unfortunately just don't really get a whole lot of benefit from medications. When you move into sort of beyond that, into the interventional or even the surgical realm, again, we do a lot of epidurals. Classically, you really shouldn't be doing epidurals for axial low back pain, but anecdotally, a lot of patients swear that it does help the back component of their pain. More commonly, what we've been doing for decades, is radiofrequency ablation. So again, if the pain is coming strictly from the facets, strictly from the arthritis of the joints of the spine, if you will, radiofrequency ablation is kind of our go-to. But again, that's only one potential source of back pain. When you look at spine surgery, again, that's also always usually has been historically entertained as a treatment for back pain. But if we just look at these last two things, so sort of the bread and butter tried and true sort of interventional stuff, you know, again, for radio frequency ablation or lumbar RFA, where you're actually going in and ablating the medial branch nerve, the nerve that innervates the facet joint. Again, in a well-selected, well-diagnosed patient where facet arthropathy or facet arthritis is really driving the patient's low back pain, again, a specific cause of back pain, RFA works pretty good most of the time, right? It actually has a grade 1 U.S. Preventive Task Force recommendation behind it. Again, not to disparage any specialties, but when you look at the data for spine surgery specifically for axial low back pain, meaning if you're going to go in and operate on low back pain, I think there's good data, or I should say lack of data, that says that you're doing a lot of good, right? So I think most ortho spine surgeons, neurospine surgeons will probably agree with this. I don't want to speak for anyone, but if you're operating specifically for low back pain, maybe outside of gross instability and things like that, the outcomes really don't seem to support that. And again, this is just taken from a very high level review article. So when I think about back pain, historically, what kind of goes into it, and maybe what explains some of these subpar or less ideal outcomes? Well, whenever I hear low back pain, these are the different sort of things that my brain goes to, right? There's maybe some yet unknown causes of back pain that we just don't know yet, right? There's still some missing links. And again, that's what we're here to talk about today, and hopefully fill in at least maybe a couple of those blanks. You can have rare inflammatory conditions that can explain axial low back pain, rheumatologic type conditions, right? And so you still have to look for the zebras sometimes. SI joint pain, well described as sort of a misdiagnosed or underdiagnosed source of axial back pain, meaning it's not the back per se, it's not the lumbar spine at all, it's actually the SI joint the whole time. So again, something you don't want to overlook. We've talked about radiofrequency ablation helping those facet joints, those arthritic facet joints. Again, in a well-selected patient, if it's driving the majority of the pain, it's a fantastic therapy. But as you can see from this slide, it's only one of many potential specific explanatory causes of back pain. Spinal stenosis, again, we think about neurogenic claudication, more of that buttock, thigh, leg pain. But I see a lot of patients day in, day out where the predominant pain is actually in the back itself. So spinal stenosis is a relatively common cause. Myofascial muscular pain, neuromuscular pain, again, usually responds well to physical therapy. Oftentimes myofascial pain is sort of intertwined with a lot of these other potential diagnoses, but again, a very common cause of low back pain. Compression fractures, one of my favorite things to talk about and treat, again, can honestly go under the radar for longer than I like to see. No one thinks to actually think it is a compression fracture, and no fault of anybody. Sometimes they're just kind of hard to diagnose. They're just not super obvious. Spinal instability, like I mentioned, oftentimes does get better with sometimes minimally invasive interventions, sometimes more traditional surgical interventions, but spinal instability is, especially degenerative spinal instability is pretty common. But what we'll talk about today are these 3 therapies highlighted in yellow. So we're going to talk about multifidus atrophy, what that is and how that can be a source of pain. We're going to talk about vertebrogenic pain. That's not a made-up term. At least I didn't make it up. And then, of course, pain coming from the disc, right? There's been a lot of things that have come and gone for disc pain, but there's a couple sort of relatively newer and emerging therapies we'll talk about today. Another way to think about low back pain is with this little picture here. So the way I think about it is, in the middle here, that's your patient. Your lock is the patient, right? That's what you're trying to unlock or figure out. And so you can look at this as a metaphor in a couple different ways. You could say, well, maybe we're missing certain keys, right? If that's not part of your repertoire as an interventional spine specialist, you're clearly missing patients and providing substandard care. But again, even with the tools you have, you still have to do a little bit of trial and error to figure out which key unlocks. Obviously, you can look at the certain keys. You can obviously eliminate, okay, this one doesn't look like it's going to fit. Maybe this one will, maybe this one will. But there's still a lot of trial and error that goes into treating low back pain, just thinking about it day in and day out. So we'll kind of stop and pause. I'll ask a multiple choice question here. So when it comes to frustrations in treating low back pain, what can we attribute those treatment failures to? Is it A, not enough treatments? Is it B, having too many treatments, like too many keys, right, to try? Is it having too many diagnoses, right? Meaning, I don't know. There's so much it could be. Like a couple slides ago, where I said that there's a bunch of different things that could be the cause of it. Or again, are there still things that, despite trying every diagnosis and trying every treatment, every key, are there still things that we just still don't know about back pain that we just don't know and we're ignorant to it? Or is it all the above, right? I like to think that it's probably all the above, right? I think in some patients you have almost feel like there's too many things to try and it takes some time to work through that. There's some patients where you try everything and you still strike out, right? Maybe it's more of the biopsychosocial sort of aspect that at play. So again, just kind of a interesting thing to stop and think about. This is actually a meme that one of my friends sent me, and I think it really describes frustrations of the spine clinic, right? It sort of encapsulates every day, oftentimes what we do in the pain clinic here, right? I'll just play the meme here. Hopefully you guys can hear it.
I don't think we're hearing it on this end.
So again, a little bit of comic relief here, but I do think this encapsulates the frustration by, again, referring providers, by pain specialists, myself included, and also patients, right? And I'm very honest with patients. A really wise doctor once said, if it seems like we're guessing, we are to some degree, but I like to think they're educated guesses. I'm completely joking. That wasn't a very smart doctor. That was actually me. And that was me probably to every patient who's ever come to my clinic with a diagnosis of axial back pain, right? I'm very honest with them. I say, look, this is where we're at. This is the reality of things. There's certainly things we can try, and every therapeutic intervention is as much a diagnostic tool along the way. So again, a little bit of break from how to think about things, but I think it's very appropriate to what we're talking about. So now that I've made you completely despondent and depressed about axial back pain, let's switch gears and let's kind of take the glass half full approach now. So the way I like to think about as we sort of move into these specific therapies and the evidence for them, we will we'll talk about, or I'll use this analogy, right, of westward expansion or manifest destiny. So what I mean by this is there's some sort of established therapies. There's more data, there's more evidence for some of these therapies I'll talk about, right? So kind of like the eastern part of the United States here. Some of these therapies are brand new. They're not even approved yet in the United States. So we're kind of thinking, well, we're kind of out here in the West, right? We're still trying to figure out, is there data and evidence for this? So this is kind of the analogy I'll use as we start stepping through these individual therapies. So there's 3 therapies we'll talk about. Like I mentioned, we'll talk about vertebrogenic pain that I alluded to. Specifically, the therapy for that is a basivertebral nerve ablation, and we'll talk about what that is. We'll talk about discogenic pain, or pain coming from the disc, and there's a couple kind of recent, interesting intradiscal therapies. And lastly, we'll talk about multifidus atrophy as a source of pain. And the treatment for that is actually multifidus muscle restoration. It's actually a form of restorative neuromodulation. So think of it kind of like a spinal cord stimulator, but with different goals and different targets. All right, so we'll talk about vertebrogenic pain. So this, what it means by definition, right, is pain originating from the vertebral body itself. We'll put this little cartoon here, this little anatomic diagram. So what we see the bone here, we see the disc above, the disc below, and we're sort of done a little cartoon cutaway of what's going on inside the disc. And so what you have here is this is your basivertebral nerve. It branches off the sinovertebral nerve here. It then branches up and down and north and south, and then it arborizes like the roots of a tree. And you have you have a lot of high concentration of nerve fibers, but also a high concentration of pain mediators, things like substance P, different interleukins, etc. So we know that the vertebral body itself is innervated. We know this when compression fractures are super painful and super symptomatic. When that bone breaks, that's why it hurts, is this exact innervation you're seeing here. So again, vertebrogenic pain can be a source of low back pain. It has pretty similar risk factors to the general risk factors I talked about before. But what we're really focusing on is these damaged end plates, and we'll talk about that a little more in a second with a video. But it's pain transmitted via that exact basivertebral nerve I was just talking about before. The pain itself, and this is a very classic, textbook patient who presents with vertebrogenic pain. The pain is midline, so usually right in the middle of the spine, again in the axial back. It's usually aggravated by physical activity. Sure, a lot of things in our clinic are. Lifting, again, it's not super specific. None of this is 100% specific. But pain with prolonged sitting is kind of interesting, right? So when a patient says, actually, when I sit for a long period of time, that's the number one thing that aggravates the pain. Or bending forward. And this is really helpful because things like arthropathy or arthritis of the back part of the spine, these facet joints on the back, those are usually worse when the patient leans back. Spinal stenosis will get worse when the patient leans back, right? You're narrowing the diameter of the spinal column with lumbar extension. When a patient says, actually, it's worse when I bend forward with flexion, a light bulb should kind of go off in your head and say, oh, this might be one of these newer things that Dr. Williams is talking about. So how do we make this diagnosis? Well, we kind of talked about what to listen for or talk about on the clinical side or on the presentation side of things. But from a radiographic standpoint, what we're really looking at are modic changes. So I used to think this is just something that you'd pin medical students on your radiology rotation, but it actually matters a lot in my space. So what we're looking for are these modic changes, it's sort of discoloration of the end plates, right? And on a T1, it's dark, and on a T2, it's bright if it's a type 1 modic change, meaning that this is a relatively sort of acute change going on in the spine, meaning it's inflammation and edema. Over time, the way I think about it is that inflammation and edema actually sort of transforms into more of a fatty infiltration. So you could also have a type 2 modic change. It kind of lights up bright white on both sequences, both T1 and T2 weighted images. These are the two types of modic changes you're looking for to decide if the patient, at least radiographically, is a candidate for this basivertebral nerve ablation therapy. Unfortunately, type 3 changes are kind of chronic, they're old, they're basically sclerotic. Those are not candidates for this therapy. So, if you see, when you're reading through a quick MRI report, if you see modic changes, again, a second light bulb should maybe go off saying, oh, maybe they're a candidate for this kind of therapy. So we'll show you this quick little video. There's no audio here, but again, a nice little video showing there's the discs, we have our vertebral bodies, we have our end plates. And over time, there's our basivertebral nerve again. So that same little cartoon I showed you. But over time, as that disc desiccates and it sort of dries out, what can happen is that the end plates get damaged and the disc can actually sort of erode or does erode into the vertebral body. And that's what causes the inflammation and those changes that you ultimately see as modic changes on your MRI. And there you go. So there's your modic changes. You've identified the patient. They have the classic clinical exam findings. We'll see here in just a second how that pain is actually transmitted through the vertebral body, through the kind of main highway here. So again, pain's being transmitted via that basivertebral nerve. And so from a therapeutic standpoint, this is what we're doing with our therapy. We're basically accessing the vertebral body. We're taking a bipolar radiofrequency probe, and then we're basically just targeting that basivertebral nerve, but we're specifically targeting it back here, kind of the posterior third of the vertebral body. Again, if we target it more downstream or distal, right, we're going to be missing this branching point. We're only going to be kind of targeting half of the innervation. So again, if you have an appropriately positioned probe here, you can basically turn off those pain signals. You can essentially de-innervate the vertebral body with this therapy. So just a nice little axial view, again, cartoon form. The way to think about this without getting too technical, it's basically a kyphoplasty without any of the risky parts, right? So we're coming right down the pedicle with our trocar, with our access needle. We're making a little channel to curve right across, again, to that back sort of 40-30% of the vertebral body. So catch that nerve before it's had a chance to branch and arborize. Throw our probe down there, cook it for 9, 10, 12 minutes, whatever dealer's choice there. And we've basically performed a nerve ablation. We've basically denervated the vertebral body. We've even though the vertebral body still has those modic changes, we've stopped the source of pain. So how about outcomes for this procedure? Well, overall, this is a really safe procedure. So multiple studies have shown about a less than 0.2% complication rate. So again, overall, a very safe therapy. This is one of the first pivotal studies that showed 2-year outcomes. And what they were able to show is that about a 4-point reduction in pain scores, which is not nothing, right? That's actually pretty significant for a lot of our patients. It was a crossover study, so you can see patients who were in the sort of conventional medical management arm eventually crossed over, and they actually reached a very similar endpoint. Basically, if you continue this sort of study and you extrapolate this out to 5 years, and 5-year outcomes in my specialty especially are kind of hard to come by. But what this SMART trial showed is that patients who responded to this therapy actually maintained that pain relief at least out to 5 years. So that's really kind of a profound, important endpoint in my world. Actually, a third of the patients were pain-free at 5 years. I never use the word pain-free in my clinic because it's just kind of an elusive goal. But, if you can truly get a well-selected, well-diagnosed patient and, match the perfect therapy to the perfect patient, there's a subset of patients that, pain-free is potentially realistic here. Pretty good responder rate. So about 2/3 of patients will achieve that 50% pain reduction, which again is fantastic. But it's not just about pain scores. They were actually able to show a very similar endpoint with ODI or disability. So patients functionally did a heck of a lot better too, out to 5 years. And there was actually quite a subset of patients that reduced opiate consumption, again, out to 5 years. So in a kind of a quick, very high level way, I think there's definitely something to this basivertebral nerve ablation. But again, it takes patient selection. It takes knowing, kind of looking at a more comprehensive view of all the different sources of back pain. So we'll switch gears a little bit here. We'll talk about discogenic pain. So it's overall very similar to vertebrogenic pain. Kind of makes sense, right? That the disc is just literally contacting the end plate of the vertebral body. Again, it's centralized axial back pain. It can cause more radiating pain. Again, if you put degenerative disc disease diagnosis in Epic, it'll ask you, is it just in the back? Does it go down the legs? Right. So, but it's aggravated by, again, bending forward. So pain that's worse with flexion actually improves usually with extension. A nice little pictogram here, a little graph. It shows what sort of positions actually increase intradiscal pressure the most. Well, basically, it's sitting down compared to lying down, but it's also bending forward, right? So if a patient says, yeah, lying down feels way better, but, sitting at work for a long period of time or, bending over to lift up my kid or grandkid, whatever it is, that should kind of cue you into maybe this is more of a disc type pain. Again, lifting, coughing, that sort of Valsalva positive pain, again, increases intradiscal pressure, should aggravate pain if it's truly originating from the disc. But again, this can still be very hard to sort out. So going back to our analogy of manifest destiny, westward expansion, I think the not to put a spoiler alert in here, but a lot of the data for these intradiscal therapies is a little bit further out, kind of in the Wild West. We're still trying to figure out what are the best targets, what are the best therapies, and so maybe not quite as established as say like the basivertebral nerve ablation we just talked about. So the first specific therapy we'll talk about is actually a nucleus pulposus allograft. It is commercially known as Viadisc. What it is it's basically a shelf-stable cadaveric nucleus pulposus, basically ground up from a cadaver. And basically what we're going to do is we're going to inject it and sort of supplement it back into the disc. So in a normal disc, right, we have this well-hydrated disc. We have lots of water, H2O molecules in there. It's plump. It's able to transmit forces and take axial load on the spine. Over time, as that water sort of leaves the disc, as the disc gets desiccated or dried out over time, it sort of loses that structural integrity, then begins to kind of wear out over time. The procedure itself for pretty much any of these intradiscal therapies is quite simple. It's a 15-20 minute procedure, just like doing basically any other fluoroscopic guided procedure, an epidural. It's basically like doing a transforaminal epidural, but just kind of going past it right into the disc space. So we use our X-ray guidance. We make sure our needle's in the right spot. And then you're injecting, whatever the therapy of choice is here. In a cartoon form, again, there's our needle. Again, we want to be kind of center of the disc in the nucleus pulposus here. And then all this magic happens. We're rehydrating the disc, and then hopefully it's the structural integrity of the disc is restored with this therapy. So just conceptually, that's what we're talking about with a lot of these disc therapies. Again, outpatient, not really invasive, pretty simple, straightforward from a technical standpoint. What about the data for this Viadisc or this NP allograft I keep talking about? Well, this is probably the major study that's out there about this therapy. So there's basically 3 arms. They compared the allograft to saline, so basically like a sham control intervention, and then they also compared that to conventional non-surgical management. Their endpoints were the usual suspects: disability, pain scores. They included 218 patients, so pretty high number of patients for this kind of study. They had either 1 or 2 levels of degenerative disc disease. It was blinded, it was randomized. They set clinical significance at a 15-point improvement in ODI. And what they found when you compare the allograft to basically conventional medical management, patients actually had a 76% response rate, right? You had improvements in VAS, you had improvements in disability here. So it looks pretty good. Again, even when those patients crossed over, they still did quite well out to 12 months. So again, when you look at it here, you're like, okay, there's actually something to this. But the caveat that I'll tell you is that when you look at maybe when you compare it to the sham procedure or the saline injection, it's not quite as favorable in my humble opinion, right? So the green is your allograft, the blue is your placebo, your saline injection. And you can see these lines actually look pretty similar. So maybe you're only talking about maybe a 10-point improvement in disability here, or maybe a 1 to 2, maybe a 3-point improvement in pain at best kind of thing. So unfortunately, when you compare the allograft to saline placebo, it just doesn't quite look as good. So again, when you kind of dig a little bit deeper into this study, it's not quite as promising as maybe you would hope or expect or want to believe. So my conclusions on this nucleus pulposus allograft is that I do think it's a novel and promising therapy. Unfortunately, there's just not, in my opinion, enough robust evidence to support widespread adoption. So this is actually nothing that we actually have at the bedside currently. Again, when you compare it to saline, it doesn't look great, but if you compare it to say maybe intradiscal PRP, which also doesn't carry a super high level of evidence, some will argue that PRP is actually probably just as good as maybe a more expensive nucleus pulposus allograft. So kind of food for thought there. But like any therapy, like I said, it's on a bell curve, right? So a lot of these patients, it doesn't mean that there's no patients that would maybe not do remarkably well with this therapy. The hard part is figuring out, and what we still need to figure out as a specialty is how do you identify these patients, right? There's some thoughts that, well, maybe patients with Modic type 2 changes would benefit better, but I think long story short is that there's just still a lot more to figure out with this sort of intradiscal, at least this particular intradiscal therapy. And not surprising, when I was putting together this presentation, I actually looked at the Medicare LCD specifically for Viadesk and this NP allograft. But the actual LCD steps through many different therapies, like a lot of things that have come and gone, all kinds of weird things like methylene blue and all kinds of fun stuff we used to inject into discs well before my time. And unfortunately, not surprisingly, based on evidence like this, it's not entirely surprising why Medicare doesn't cover this particular therapy. So again, a novel approach, a novel concept, but just unfortunately hasn't really panned out in my opinion. So this is even less of a established therapy. So the other thing that we're going to talk about here as far as intradiscal therapies go is Genopin. So it is a novel injectable spinal disc stabilization product. It's commercially known as Intralink. It's actually a naturally derived compound, if you will. But what it does is that it's called a polymer forming collagen bonding substance. The way to think about it is that it just cross-links collagen molecules, right? So it strengthens the connection of collagen and that sort of connective network or connective tissue. The difference with, say, the NP allograft is that with this, we're actually injecting it into the annulus. So kind of the ring or that donut-shaped tough connective fiber of the disc. So very similar, but with a subtle nuance. Again, this is a pretty novel therapy. So this is really, this is the only public or publicly available study that I could find or that I know of and even asking around. And so this is a very small sort of first step investigational study, only 20 patients, but they just want to say, hey, is this safe and is it potentially effective? So again, only 20 patients, very similar sort of study, degenerative disc disease at 1 or 2 levels. They did your X-ray fluoro-guided injection. They injected two spots, or basically 2 injections at each level. Their primary endpoints was, again, is this safe? Were there any major side effects? And does this actually help with pain and disability? Their secondary endpoints were the same endpoints, but just a little longer. And then they also looked at spinal instability as well through some different kinematics. And so this is kind of the takeaway here, right? So patients who got the Genopin, if you will, they actually got relief pretty quick, like right out at 2 weeks. And you could argue based on this blue line, right, that actually, gosh, it actually sustained, it almost continued to improve out to 12 months, the endpoint of the study. But if you look at the 2 different lines here, so the red line is patients who are greater than 85 kilograms, and the blue is patients who are less than 85 kilograms. So their conclusion from the study was that, well, there's sort of this fall off in pain and ODI improvement for high mechanical demand patients. So again, higher weight, higher BMI patients. So that doesn't necessarily mean you need to throw out the baby with the bathwater. It just says, well, the question I would ask is, well, do these patients just need a second or a repeat treatment down the road? But the other conclusions from the study, fortunately, was that there was no serious adverse events. 80% of patients actually did report improvement in pain and disability. So again, a promising statistic. The kinematics, and I'll be honest, I forget the details of what they were looking at, but I think it was kind of like flexion extension X-rays, angulations of functional spine units, et cetera. But the kinematics were slightly less supportive, which doesn't necessarily mean it's good or bad. And my takeaway personally from this is that, well, maybe, again, this is still a novel therapy. It's not even available in the United States yet, but maybe it's an ideal therapy for our younger patients with sort of earlier stage degenerative disc disease who are maybe non-obese, right? So maybe this is a great way to prevent, unnecessary other procedures, surgeries, et cetera, in kind of a novel patient population. So the other nice things to point to is that, hey, if I can get improvement onset at 2 weeks, that's great for my patients. And if I can confidently offer them pain relief out to 12 months, that's really good, right? So when you compare that to, say, epidurals, where sometimes patients come back, 3 to 4 times a year, or nerve ablations, where they're coming back sometimes, no more than 2 times a year. Again, just comparing it to what we already have, I think this is definitely a promising therapy. But like I said, a lot more that needs to be done on this therapy. So the last thing we'll talk about is multifidus atrophy. Going back to our analogy, I'd sort of rate multifidus atrophy, again, maybe not quite like our first, colonies, but definitely more of an established therapy with some more, I'll say, convincing data. So what is multifidus atrophy? Well, again, it's a sort of mechanical pain of the low back. So it's another culprit in mechanical low back pain or axial low back pain. I say recalcitrant because it just seems like oftentimes these patients, when they present with a lot of other failed therapies. They've tried epidurals, they've tried RFA, but just nothing seems to work for them. What is multifidus atrophy? Well, let's just look at it in an MRI form here. So here's your axial cut. You have your disc or your vertebral body right here, spinous process there, facet joints on the side, and then your central canal right here. So when we're looking at the multifidus muscle, we're looking at this muscle right on the side of the spinous process here, tucked in right here. And in the normal patients, this is what it looks like, right? So black is muscle, white is fat. It's a terrible analogy, but the best way I can say is think about it like your filet mignon, right? So what we want for patients is a terrible, tough piece of meat, right? We want that to be completely blacked out, all muscle, really, really strong muscle tissue there. As you move from left to right, you get a little bit of fatty atrophy, right? Fatty infiltration and muscle atrophy. So this is looking more like a piece of steak that maybe you'd want to, put on the grill, right? It's got some flavor and marbleization to it. Again, good for dinner, but not good for our patients kind of thing. And then if you get over here, like you're well into your A5 Japanese Wagyu, right? Tons of fatty infiltration. This is what it looks like schematically, right? Just basically more fat than muscle, right? So again, just not really good from a low back pain standpoint. It's kind of a particular type of pain, right? And this can take some questioning and some subtle nuance, but oftentimes patients can kind of get through their entire exercise routine, but it's very particular activities where they feel pain. It's what we call low load motor exercises. So it's saying, hey, I can bend over and pick things up. I can do a weight routine, but they're saying, I just lean forward a little bit, like maybe 20, 30 degrees kind of thing, just to brush my teeth or wash my dishes or, unload the dishwasher. That's where I really notice that pain. It's just with a little bit of forward flexion. Sometimes these patients will describe more of a back spasming sensation. So sometimes that's where the light bulb can go off too. These patients will describe, of course, pain, but sometimes they'll describe more of like an actual muscle fatigue with standing. They might find, back rest or braces helpful to kind of give them that support that the multifidus muscle is not giving them. Again, you can't have leg pain, with this and in general, but just you have to be very clear with patients if you're talking about the treatment for this, which is, hey, this is only going to help your low back pain. You might have something else going on with your legs. You might have some other pinched nerves, but it's really primarily for low back pain. These patients they really shouldn't have had previous spine surgery. When you have, especially fusions, we know that the multifidus muscle is going to atrophy anyway. So by and large, these are patients that this is not like a last ditch effort, right? So these are not patients who've got a stimulator, got a pain pump, et cetera. The underscoring point here is that these patients really, this shouldn't be a last line therapy. This is, hey, if they have these appropriate diagnostic findings and they present with, and you think multifidus atrophy is the ultimate source of their pain, you should be offering them this therapy, arguably as a first line therapy, right? So it's not necessarily like a salvage thing, but again, patients who've had previous spine surgery, they really tend not to do well with this therapy, just different pathologies. So what is the lumbar multifidus muscle? Well, it's actually the most important spinal stabilizer. Basically attaches here to the spinous process, comes down, attaches to the superior articular process, but it kind of forms this mesh network spanning a couple different levels, and it ultimately anchors into the sacrum or the posterior superior iliac spine. Right. So the way I think about it is that it's kind of a nice counter traction or kind of counter pulley, if you will, to kind of maintain erect upright posture. So again, as you sort of flex forward, that's where that multifidus is engaging most to kind of help kind of load or stabilize those muscles as you flex the lumbar spine. Can be injured for a number of different reasons: age, injury. Unfortunately, with spine surgery, for better or for worse, oftentimes that multifidus muscle is iatrogenically injured or completely scraped off, its attachment points. So again, that's what the multifidus muscle does. That's why it's an important muscle. I'm not going to go into too much detail here with the physical exam findings, but just know that there are some physical exam findings that are specific for multifidus muscle atrophy. The simplest one is the toe touch test, So, basically you just ask the patient to bend forward and then just come right back up. Basically, if it's a smooth motion down, but also a smooth motion back up, multifidus atrophy is probably not your culprit. But if the patient kind of walks their hands up their knees, then kind of groan and they kind of sway back and forth, that might be a clue that, okay, maybe there's some multifidus atrophy at play. Again, there's some more, again, these other two tests, the PIT test, the multifidus lift test, they actually have pretty good inter-rater reliability, but there's a little more nuance that goes into the physical exam findings. But just know that on physical exam, this is another good way to identify these patients. So what is the actual therapy I'm talking about here? Well, it's multifidus restoration. So you look at it and it looks kind of like a spinal cord stimulator, right? You have an IPG, right? You have some electrodes coming in here. The difference is we're not putting it into the epidural space like we do with a spinal cord stimulator. We're actually putting these little tines, these little electrodes right on top of the medial branch, right? So the medial branch, not only does it innervate the facet joints, which is why it's a target for RFA, where we're sort of ablating the nerve to turn off those pain signals coming from the facet joints. But the secondary function of the multifidus muscle is that it actually provides contraction and innervation to the multifidus muscle. So it's a paradigm shift. We're saying, hey, instead of ablating and destroying the medial branch nerve, maybe we can restore it and build it back up, right? So what we're doing with this therapy is we're actually restoring the whole neuromuscular connection, right? Almost retraining the brain how it interacts with the low back. And certainly physical therapy can put a good dent in this, but there are some patients who physical therapy fully can't restore the multifidus muscle. So the other way to think about this is that this is, again, it's an implantable device at the end of the day, but it's kind of like on-demand physical therapy. So patients run it 30 minutes a day, 2 times a day, and it just kind of beefs up that multifidus muscle, right? There's no trial period, right? There's not really like a psych evaluation that we do because we're going straight to the therapy. But the interesting thing is when you look at the clinical studies, patients the first 3 months, you really don't know how helpful this therapy is. So the first 3 months could be placebo. And that makes sense, right? We're trying to restore a muscle, right? No one goes to the gym after just 2 times and then all of a sudden they're jacked and they look like Arnold Schwarzenegger, right? It takes time, weeks, but really more like months to know. So the point here is that this takes commitment from the patient too, right? They could be the perfect candidate, but if from a radiographic standpoint, from a physical exam standpoint, but yeah, if they're like, say, I want a quick fix. I don't want an implantable therapy. I don't want to wait 12, sometimes even more like 14, 16 months, et cetera. This might not be the right match for your patient. So quickly get into the data here about multifidus restoration. Commercially, this therapy is known as Reactivate. So they did a multi-center RCT, 200 patients randomized to this multifidus stimulator device or conventional medical management. Average patient age was a little on the younger side, maybe 47 years old, but again, a staggering statistic, 11 years was the average time these patients have been suffering with back pain. Kind of underscores the whole point I was making earlier on in this talk. But the primary endpoint was actually disability. They were saying, do these patients functionally do better? Of course, they looked at pain, they looked at quality of life as well. To cut to the chase here, again, some really nice endpoints at 12 months. You see a nice separation. This is the kind of improvement in ODI. And at 12 months, again, it takes 12 months to really know how helpful this therapy is oftentimes. But patients were improving about a 20 points, so a very clinically significant improvement in ODI. Pain scores, very similar, right? We're talking approaching a 4, maybe even a 5-point improvement in pain scores, again, over 12 months. But like I was talking about basovertebral nerve ablation, we actually have 5-year data on this intervention. So that's actually a really cool thing. So the Reactivate B trial, it was a prospective randomized double blind. They actually did a sham control, which I think is I'll give credit to the authors of the study. But they basically continued that protocol out to 5 years. And what they showed is that 4 to 5 point improvement in pain scores sustains out to 5 years. That 20+ point improvement in disability sustains out to 5 years, again, in well-selected, well-done patients. And interestingly, going back to opiates, almost half of them discontinued opiates, which is always a great thing. And at least a quarter or so decreased their intake of opiates. So again, it's really nice to be able to offer 5-year data. And again, the responder rate at 5 years is pretty good, about a 70% responder rate for pain and about a 60, almost a 2 out of 3-ish out of patients will respond from a functional disability standpoint as well. So my quick take on this, or the quick conclusion on this multifidus restorative therapy, it's the first prospective study that I know of that looks at a neuromodulatory device specifically for treating chronic low back pain, again, with a 5-year endpoint. So a pretty novel paper in and of itself. The outcomes as far as infections, et cetera, explant rates, whatever it is, was pretty similar to spinal cord stimulation. So about as risky as doing spinal cord stimulators, which are pretty ubiquitous in our specialty. But again, some nice efficacy and some nice durability endpoints. There have been some cost effective or some cost analysis papers that actually show, hey, yeah, if you put this device in, sure, it's expensive, it's implantable, but it kind of makes sense if you're able to show disability improvements and pain disimprovements out to 5 years. That's a lot less of repetitive nerve ablations and just kind of the wrong therapy for patients. So I do think you can make a cost effectiveness argument pretty easily. And I think, again, just knowing that multifidus atrophy should be considered sooner in the algorithm, right? So just because a patient, if they have all these findings that I just talked about, there's no reason to withhold this therapy from a patient who this is probably the better answer, right? Rather than doing just a tried and true or a sort of a formulaic approach to low back pain. So last slide here, guys. I appreciate you hanging in there. I think just step away from this conversation or this presentation today, just knowing that there has been progress with diagnostic targets, right? So we are finally moving away from just nerve ablations and epidurals, right? There's these new diagnostic targets. To be fair, a lot of these studies, unfortunately, they're just industry sponsored. That's just the nature of the beast. But it's nice to see like basic science and basic clinical evidence and kind of driving the therapy at the end of the day. So actually just really looking into sort of novel avenues. Again, there's variable degrees of acceptance and data for all these therapies, as you said, going back to my analogy of westward expansion. Some of these things, 5-year data, right? Really, really convincing data for a lot of these things. But there's some other things like discogenic treatments. It's just a little bit harder to pin down as far as a efficacy standpoint. It's low back pain. It's going to continue to be a diagnostic and societal conundrum. Again, I don't think this is going to change from 90% non-specific to 30% non-specific or specific pain, whatever it is. But just know that again, it's nice to see that we're making some headway with these issues. And I think the last thing to point out is that it underscores the importance of at least being facile and being proficient in these different modalities, right? As a practitioner, as an interventionalist, if I'm not offering all the current state-of-the-art treatments to all my patients, you're clearly missing, right? You're missing patients, right? You're missing good outcomes and missing, diagnostic, important things, right? And from a referral standpoint too, I think it makes sense, right? If you refer to a physician who offers all these novel therapies, right, you know that you're probably offering better treatments and matching better treatments for patients at the end of the day. And that's what it's all about, is getting it right for our patients at the end of the day. So with that said, that's all I had for you guys today. Appreciate your attention, and I'll answer any questions if anyone is still hanging in there.